Welcome to Nuances of Direct Oral Anticoagulants. This is part 2 of the knowledge section. Learning objectives for this section include discuss standard practices for starting and monitoring DOACs, including baseline tests, follow-up, and evaluation. Assess strategies for avoiding drug-drug interactions and managing dosing errors with DOACs. This first table illustrates a comparison of the DOACs with regard to dosing and pharmacokinetics. The top row illustrates approved indications for each of the DOACs, followed by the mechanism of action, the time to peak activity, the bioavailability, and the plasma protein binding for each of the DOACs. One should note that for edoxaban, its indication for non-valvular atrial fibrillation is limited in that edoxaban should not be used in patients with creatinine clearance of greater than 95 milliliters per minute. This is due to the fact that the risk of stroke was elevated in these patients for edoxaban compared with warfarin. This table continues to list some factors in considering the dosing and pharmacokinetics of each of the DOACs, including the volume of distribution, the plasma half-time, the metabolism, and the excretion of each of the DOACs. Of note here is that the half-life of rivaroxaban is 5 to 9 hours, and yet the recommended dosing is only once daily. This has led to some question in the cardiology and hematology community regarding the efficacy of once daily dosing of rivaroxaban. This table continues to list the recommended dosages relative to the renal function of the patient for each of the DOACs, for non-valvular atrial fibrillation, for DVT or pulmonary embolus, or in people with recurrent DVT or pulmonary embolus. Attention should be paid to the fact that rivaroxaban should be taken with the evening meal. This recommendation is often missed for many physicians and patients. Apixaban should be given at reduced dose of 2.5 milligrams BID if 2 of 3 characteristics are seen in the patient, including creatinine of at least 1.5 milligrams per deciliter, age of 80 or higher, or weight of 60 kilograms or lower. Again, edoxaban is not recommended when the creatinine clearance is over 95 milliliters per minute due to the finding of higher rates of ischemic stroke in this population. This table has some additional comments regarding DOAC, dosing, and pharmacokinetics in the treatment of DVT and PE prophylaxis, as well as some final dosing comments. Of note, rivaroxaban and apixaban should be avoided in patients with severe hepatic impairment, and edoxaban should not be used in people with severe renal dysfunction with creatinine clearance of less than 15 milliliters per minute, and in patients with moderate to severe hepatic impairment. This table illustrates some comments regarding measurement of therapeutic effect for the DOACs. As can be seen in the top row of the table, routine monitoring of therapeutic effect is not required for any of the DOACs. However, some hematologic testing can be done to assess therapeutic effect. For example, the dabigatran effect can be assessed with the measurement of APTT. Rivaroxaban, apixaban, and edoxaban can be assessed by measuring anti-factor Xa activity. However, it should be noted that these tests may not be reliable and that there is little experience using these tests to guide clinical decision-making. It should be noted that DOACs may have multiple drug-drug interactions. Notably, dabigatran has interactions with glycoprotein inhibitors, which include the azole antifungals as well as dronedarone. Rivaroxaban also has significant glycoprotein interactions with other commonly used cardiac medications, which include diltiazem, verapamil, amiodarone, and dronedarone. Edoxaban, as well as apixaban, which was listed on the previous table, both have potential interactions with the azole antifungals, as well as verapamil. For routine DOAC initiation and monitoring, the patient's age, as well as body weight, are very important. Concomitant medication should be assessed, and notably interactions include dronedarone, calcium channel blockers, and amiodarone. Renal function should be measured before initiation and during treatment, and hepatic function should also be monitored and should avoid DOACs in patients with severe liver impairment. To review, the learning objectives for this part include discuss standard practices for starting and monitoring DOACs, including baseline tests, follow-up, and evaluation. Assess strategies for avoiding drug-to-drug interactions and managing dosing errors with DOACs. This concludes part 2 of the Nuances of DOACs knowledge section.